Thank you. I want to thank the organizers for inviting me. I want to thank my hosts, Mr. Ebanks and Tamara. And I got to say that I've gotten so much out of this meeting. It's kind of recharged me in terms of hope for medicine, which is what my interest in amyloid has really been done. I guess the question you're asking is, why am I giving this talk? What am I doing here? Cardiac amyloid is really a multi-system disease that's been poorly diagnosed but prevalent everywhere. 3 to 4% of Afro-Caribbeans, as you'll see, have the gene for it. Many people have the disease. It's becoming a cause of heart failure that's unrecognized, but in order to really find this disease early and change the treatment, we have to find it early, and we have to kind of look outside the box in terms of, as somebody was talking about, the difference between being a physician and a doctor today. But it's a difference between the art of medicine and the science of medicine in order to treat these people. So if you'll indulge me, I'd like to take you down the pathway from the history, the present, and the future of our management of disease, and how we hope to get treatment down here for the people in Cayman. These are my disclosures. So I'm going to tell you about a case. 76-year-old Afro-Caribbean male with a history of a pacemaker, no history of diabetic, but he was hypertension, had coronary disease. Went to his cardiologist that said everything was good. He did a stress test on him, because that's what we do in America when we want to do a test on somebody, and he said it was negative. His ejection fraction was 48%, which was mildly reduced, but his atria were enlarged and he had left ventricular hypertrophy, and this is not a normal echo for an otherwise 76-year-old healthy male. So he presented to the emergency room with abdominal pain, 20-pound weight loss, shortness of breath, inability to walk. Had a long history of numbness in his hands and his toes. He had cervical and lumbar radiculopathy, and he just couldn't walk at all. His NT-BMP, the heart failure marker, was 3,200, which was high, and his troponin was 0.66, which is also elevated. So this, from my point of view, is a really sick person. Exercise, electrocardiogram didn't show much of anything except an incomplete right bundle branch block. And he's got an echo here that you can really see this heart is thickened, okay? Normal heart size would probably be half of this on the echo. So they came up with a bunch of potential diagnoses on him, and they sent him home. Now, this was Cleveland Clinic. They didn't tell him why he was sick. They didn't come up with a plan for him on what to do. They told him to make his own appointments to neurology and GI, which didn't really help. And he stayed in the hospital for 36 hours, because the bonus is not keeping somebody for a long period of time. But we didn't do anything for this patient. We didn't help him. We didn't make any diagnosis. Finally came to see me in cardiology. He was weaker. He was short of breath. He couldn't swallow. He was losing weight. Now he had atrial fibrillation and an ejection fraction that was markedly decreased to 20%. And I did amyloid imaging, which we'll talk about later, and I did genetic testing. But to me, when I see this combination of symptoms, and to me, that's cardiac amyloidosis, okay? And that's amyloidosis, where this heart is thickened, the right side of the heart is thickened, the left ventricle is thickened, cavity is really small. Those of us who went to med school learned that this was a disease of high filling pressure, so that's why you got short of breath, but really it's a disease of low cardiac output. Your stroke volume is small and you can't increase it. I did a PYP scan, which is the standard non-invasive test, which you can see is positive, and we'll talk about that more later. But there's nothing else that takes up that isotope except cardiac amyloid, and he got tested, and they had the V122I mutation, which is the one that's most common in Afro-Americans, Afro-Caribbean. And this is typical of what happens. These people have delays in diagnosis. They see 2 to 3 doctors or more before the diagnosis is made. AL, which is a bone marrow type, they may see 5 doctors. TTR, which is broken down into both transthyretin, which is broken down into both the hereditary and the wild types, there's a 3-year delay in the diagnosis being made. So this is a paper that came out of California, and I don't expect you to read that. But when you look at it, you can really see here the time from the last symptom, a year to a year and a half, and the time to the first symptoms was almost 4 years. So we're missing the boat in finding these people. And that's really the key, is to make people aware. If you look here on the left slide in the purple down below, you can look at the V122, and you can look at the prognosis of these people, where more than half of them were dead at 4.5 years. And if you look at the right, which is the wild type, you can see again at 5 years, about 40% of them. So this is a malignant disease at the time of diagnosis that we have now, and before institution of disease-modifying therapy. So why is it hard? What do we need to do? Number one, we need to find engaged clinicians. You know, when we talk about burnout, you know, and patients barely getting through the day, it takes a long time to talk to one of these patients. You got to review a lot of records. You got to sit and talk to them. They want to know what's going on. So if they're not interested, we're wasting their time. But pharma in the U.S. is perfectly willing to talk, take 3 people out to dinner, give them a steak dinner, and hope they'll get 1 prescription. You need to have a champion. We need to raise the ability to suspect these diseases, which is where the primary doctors come into play. When I was an intern, many, many years ago, and somebody came into the hospital with a right lower quadrant pain, I called the surgeon 90% of the time and said I had a patient with appendicitis. 80% of the time I was wrong. The surgeons hated me. When I was a second-year resident, I got a little feedback, so I knew what to do. 50% of the time I called them, and they said, yeah, they needed to have a workup. And by the time I was the senior resident, I and the surgical senior resident got along, and we could do pretty well, because about 80% of the time when I called them, it was appropriate. And so that's what we need to do, is to try and educate these people. And it's been a real problem, I can tell you, in the U.S., but I think in a smaller population where everybody's working together with healthcare, it really has some opportunities. We need to treat these people heart failure better. We need to have access to disease-modifying therapy. We have 3 in the States. We need to get it down here. We need to get it in the Caribbean. I'll tell you a little about it, and we're working on it. And we need centers of excellence. Not every place can be a center of excellence for this disease. Just like when somebody has cancer and they want to go to Sloan Kettering or MD Anderson to get a second opinion, we ought to be able to find access where we can help them for a second opinion. I have over 400 patients now. We have over 600 patients. Obviously, we are a center of excellence, and we can probably offer to almost anybody who comes something that'll help either the patient or the doctor. Okay, so now let's talk a little bit about the disease. I gave you the run through in the background, but let's talk about the disease. So transthyretin is a protein, okay? It's made in the liver, and it's used to carry thyroid and carry retinol, which is for the eye around. It's not the most important thing, but in the abnormal state, it normally makes this tetramer here, a square, a 4-leaf clover, whatever you want to call it. But either because you have the hereditary gene, or as you get older, your body doesn't make such a good protein. It's called abnormal proteostasis. But those bonds fall apart. And then these, what we call tetramers, break apart into dimers and then monomers. And when these monomers, what happens is they unfold, they clump together, they can no longer be soluble in the bloodstream, and they end up being deposited into the heart and into the nervous tissue. So the heart gets thick, the heart gets small, the atrium gets enlarged, they get atrial fibrillation, they get ventricular arrhythmia, and they get heart failure. And that's basically the disease. So if we can find people who aren't that sick and get into the way of the breakdown of this tetramer to everything else that follows, we have a way to halt the progression of disease. We suspect there are 50,000 people in the world with hereditary ATTR. We suspect there are 200 to 500,000 people in this country with wild-type ATTR. So we're talking about 300,000 minimum, maybe 500,000 patients who have this disease. So it's not a small number. When you think of healthcare dollars and quality of life and number of people impaired, it's a staggering amount of disease. We talk about heart failure with preserved ejection fraction, with normal ejection fraction being 50% or more. 13% of those patients who have heart failure with preserved ejection fraction have amyloid. That's a significant amount. And as you go into the Afro-American population, male above 70, this number may be 25% of these people who present with heart failure. I'm not going to go over this in detail, but you can see here how there are multiple red flags. And so you have to remove your preconceived notions. You have to walk into the room with no pre-expectations. You have to have a clean whiteboard and look at the patient and talk to the patient. What we also do when we're in this setting of siloed care, so we have to break up the silos, and everybody has to look at everything, because if you're only looking in this small piece of what you're doing, just the echo findings or just the carpal tunnel syndrome, you're going to miss this disease when it's right in front of your face. Okay, here's a slide that I talked to you about. Again, 4% of blacks have it. It's predominantly in male. These people present with both cardiac and peripheral neuropathy findings. So what we used to say was an elderly black male who was out of shape, who had hypertensive heart disease, and he used to say, you got to exercise. And he'd say, I can't. And I'd say, why? And he said, well, I get short of breath. Well, what happens is he stands up, he's been sitting a long time, he drops his blood pressure. I told you his heart is really small and it can't pump more blood. The blood pressure starts to fall. He gets up and goes to the bathroom and he gets dizzy and he passes out. This is real disease that we missed for years and years and years. So, I call this an orthopedic annuity. Okay, 10% of patients who have bilateral carpal tunnel have amyloid. 50% of patients who have ATTR cardiomyopathy have bilateral carpal tunnel. The time between the two is 10 years. So going back to that slide that I showed you originally, the amount of time we have to find these people early in disease is significant if we can just open up our eyes and really look for it. A third of patients who have spinal stenosis stained for positive, trigger finger, multiple joint replacements, history of rotator cuff surgeries, knee surgeries. These people are walking in as orthopedic disasters. They can barely walk. You add to them the heart failure they have, and they really can't do anything. When all they really want to be able to do is get in the car, maybe get to the airport and get in a wheelchair and go see their grandchildren, or go play, go somewhere and go out to dinner with their wife once in a while. But it's a debilitating disease with an incredible mental toll with it. We have begun to stabilize the disease from a cardiac point of view. And as such, we begin to see GI manifestations. Nausea, vomiting, constipation, diarrhea, bloating, the whole thing. It comes from a variety of different things. You can have infiltration of the mucosa. You can have neuropathic findings, so that diarrhea, the autonomic control of the GI system isn't working. Well, you can have vascular problems because the fibrils that are in the interstitium compress the small vessels within the GI tract, and you get ischemic bowel. The other thing we begin to see is neurologic manifestations. Now, when you're looking here at the hereditary type, it's clear that there's neuropathy with this. So from that point of view, you'll see people with numbness that begin in their toes and go up to their knees and even higher. And when it goes up the legs, then it starts going up into the hands. You have the orthostatic hypotension, which causes them to get dizzy and stand up and no longer be tolerant of the blood pressure medicines that they used to be on. Often they'll get foot drop. They'll have trouble walking. And most importantly, they'll have balance issues. All right, so they're walking with the walker, and it's really hard to get a patient to use a walker. When I explain to him, you're better off using a walker than not using it, because if you can train yourself to walk to the back of the room with a walker and you only have to walk over there, you'll be able to do it. It's like an athlete who trains to go 5 miles and only has to go 3 miles. And we're beginning now to see some sort of neurologic manifestations also in the wild type also, as we've stabilized the heart disease. So where do you start looking? You can start with the electrocardiogram. We all were taught that there was this classic electrocardiogram that was supposed to show an infarct pattern or poor R wave in V1, V2, and V3, and low amplitude in the limb leads. There is no EKG that's absolutely diagnosis of amyloid, and there's no EKG that somebody can have that rules out amyloid. So regardless of what you see on the electrocardiogram, don't let that dissuade you from working up the patient for amyloid if necessary. Okay? So where do we go? Well, the gold standard was always endomyocardial biopsy. Now, we didn't do a lot of endomyocardial biopsies because we didn't have anything to treat that with. But the two things that have happened in the last 10 years that we've been able to have drugs to treat the patients, and we'll see we have non-invasive ways to diagnose this without doing biopsy in about 80 to 90% of the cases. Echo is fairly typical but not diagnostic, and I'm not going to go over all of this, but basically a thickened left ventricle, a thickened right ventricle free wall, biatrial enlargement, evidence of pulmonary hypertension and low stroke volume, and we'll talk about strain in just a minute. If you look at these echoes all kind of look the same in terms of the thickness of the heart there. So the question, which is amyloid? This is somebody who has hypertrophic cardiomyopathy. This is somebody who has hypertensive heart disease with renal failure, which may be real. This is the patient who has Fabry's disease, and I've yet to see one of those. And this is the patient with amyloid. So the echo alone is suggestive, but it's not diagnostic. And the procedure done called strain, people familiar with strain or not? Okay, so basically what strain is a measure of longitudinal shortening of the heart. So if I have a rubber band and I stretch it and let go, it comes back a lot, okay? And if I'm using have a stone in there, and it's going to go a long way. If I take a real thick rubber, like a tourniquet or something, it's not going to pull back so far, okay? And it's not going to therefore move in as much. That's decreased longitudinal strain. So what we see here is you're supposed to have high numbers in the minus sign, 10, 20, minus 18 is the cutoff. And then as you go out to the outside, we often lose that abnormal strain, and that's called the cherry on top. If you have it, it's fairly diagnostic, but not good enough. If you don't have it, it doesn't mean you have amyloid. If you have reduced global strain, then it's really up to your echocardiographer to really decide whether it's suggestive or not, okay? But what I'm going to talk about, if you're an echocardiographer and you want to help people make the diagnosis of cardiac amyloidosis, you can put all sorts of ratios that were on that previous slide and things like that. If you say there's severely increased wall thickness, only 4% of patients undergo cardiac testing for amyloid. If you say there are findings consistent with cardiac amyloidosis, which we do routinely at Cleveland Clinic, 40% of these patients undergo amyloid. So if you want to increase your likelihood of finding amyloid in this patient, this is a real simple, easy way to start. Okay? CMR is helpful. I know you have CMR down here. CMR seems to be the pathway that advanced heart failure goes when it looks for amyloid or any kind of cardiomyopathy. Much of the American treatment of amyloid often comes from the non-invasive nuclear cardiology world, so we go direct to nuclear cardiology. But there are some things that are important in the MR that's important and may be useful in following disease. You can see findings like increased thickness, left ventricle, right ventricle. You will see late gadolinium enhancement in a pattern not consistent with a myocardial infarction, so it'll be diffuse. You'll see an increase in what's called T1. T1 has, and the reason you see this extracellular volume with T1 is because you have all this interstitial tissue. And so we have a few things that we can look at that it may be helpful. Again, diagnosis of amyloid cannot be made alone in America just by MR in order to get approval for drug therapy. FAT-PAD, many of you learned about FAT-PAD for AL amyloid. It's not bad for AL amyloid. It's not very good for transthyretin amyloid, okay? Less than 50% of patients will be positive for that. I don't do it. It's easy to do. If it's positive, then you skip the few steps and you don't have access to everything else. But now that we have other ways to evaluate non-invasively, I think there's not much of a role for FAT-PAD biopsy. So what really made the difference is technetium pyrophosphate imaging. Okay, that is what we use and has been around for a while. Actually, I'm old enough to have used technetium pyrophosphate to image patients for an acute myocardial infarction because it binds to the released calcium. Now, we don't know why this works with amyloid, but we know that it does. Okay, so let me just take you through a little bit of it. Does everybody have availability of nuclear imaging? Yes, no? Anybody have available the nuclear imaging with SPECT? Yes, no? Okay. So, this is the first paper that made us really realize that it was there. And we really looked to see if there was uptake in the myocardium. And what we initially did was we compared the uptake here to the uptake here. It was called the heart contralateral ratio. Now, the purpose of this paper was not to distinguish amyloid but no amyloid, but to distinguish TTR amyloid from AL amyloid. TTR took it up, AL amyloid didn't take it up. Why? Because if I put my region of interest here where there's no bone, you're going to get a higher ratio. If I put my region of interest here, you're going to get a lower ratio because there's no heart over there. So, all of the cardiac literature suggests do not use this ratio. I cannot tell you how many of patients who've been misdiagnosed, yay or nay, because radiologists often base their report on the heart contralateral ratio. Rather, we got to look at the images. We can look at the images on left with planar. We can look at the images on right with SPECT. Okay, with the planar images, you can, if the myocardial uptake is equal to bone or greater than bone, that's grade 2 and grade 3, that's positive. And if you have ruled out AL amyloid, you have made a diagnosis of ATTR amyloid. If there's no uptake here, then you ruled out ATTR amyloid to a great degree. There are 4 mutations that do not take up TTR, but that's why I would do my genetic testing anyways. The issue is here when you have a little bit of uptake, particularly when you image at the wrong time and things like that. I report this as abnormal but not diagnostic. If you get a report that says mild uptake, less than bone, you have to do more testing to make the diagnosis. How do we do more? Well, we can do SPECT. And SPECT is really easy to make us see the uptake here. It's in the myocardium. It's not in the blood pool here. Sometimes we see partial uptake, but it certainly helps us a little bit where we don't see it here and we don't see it there. Okay, so that's the grades that we use for pyrophosphate uptake. And we've eliminated biopsy in approximately 90% of the cases. Okay? This is what I call the hamburger sign. Okay, either you see uptake in the blood pool and no uptake in the myocardium, or the other way around, you'll see uptake in the myocardium and not in the blood pool. But here you can clearly see with SPECT that that uptake that you see there is in the blood pool. So SPECT allows us to more carefully make the diagnosis. Easily done in any place that has a SPECT camera. Any place that's doing myocardial perfusion imaging can do this isotope. It's cheap, it's not expensive, okay? And when you do this, if you've ruled out AL amyloid by checking the clonal testing for monoclonal proteins, your accuracy is sensitivity, specificity of about 100%. So that's pretty good, okay? So again, you should not, the study is reported as not suggestive of ATTR amyloid when it's grade 0, when it's grade 2 or 3. If AL amyloid is ruled out, and I put that in the report, it's consistent with amyloid, and for grade 1, I say further testing is needed. That's enough to tell the referring doctor they need something done, but you're not telling them exactly what they have to do unless you call them. Okay? How do we do ruling out for AL amyloid? Well, it's pretty simple. We measure serum kappa levels, serum lambda levels, serum immunoelectrophoresis, urine immunoelectrophoresis, and we just look for the ratio. So average ratio is between 0.26 and 1.65. If you have a much lower ratio, that's almost certainly consistent with AL amyloid with a lambda predominance. But as you get older and as your GFR goes down, you're allowed a little bit of a higher ratio. You need to learn to work with your hematologist to decide whether he needs to see the patient or whether you can just do a curbside consult and say, I think this guy has TTR amyloid, what do you think? Now, there's been a shortage in the last 2 years of technetium pyrophosphate. It's the kit that makes the pyrophosphate, it's not the technetium. Over the short term, we use something called HMDP and DPD. And many of us now at Centers of Excellence have not gone back and forth. We just stick with DPD. Same isotope, pretty much same way to acquire. The difference is, and I'm not going to go over it in great detail, but the clearance from the heart is much earlier, so we image these people at around 1 to 1.5 hours. The images actually look better. You get more accurate assessment. And so when you're looking for somebody with amyloid, I really focus on what's the right side, okay? You know, cardiac scintigraphy, ruling out AL amyloid, making sure that you don't have false positives, and I even do the genetic testing at the same time because, at least in America, many people who are Afro-Caribbean, Afro-American don't always come back, and you want to be able to get them for as much as you can, as soon as they can. ATTR cardiomyopathy may coexist with underlying heart pathology, and we still have issues with that in America. Okay. As I said, it can cause angina. We do have patients with coronary artery disease. They may present with chest pain. If you do a routine SPECT test on them, it's normal. You stop at that. Now, if you were to do a PET scan and look for myocardial blood flow, you at least would pick up an abnormality, and then you'd have to decide whether you're doing a cardiac cath or just going to assume that that's something going to lead you to amyloid. But they certainly can have microvascular disease. The important thing is aortic stenosis, okay? 1 out of 7 patients who presented for TAVR, or transcatheter aortic valve replacement, had a positive PYP scan for amyloid. That's significant. And 2 of those people died very, very early. So we need to begin to decide how we assess people for the coexistence of ATTR amyloid and aortic stenosis. Now, there's a little bit of a complicated scale. If you've got a nurse or somebody like that who could do that, it's real easy to do. Carpal tunnel, right bundle, age, troponin, thickness of the myocardium, and you can see sensitivity is really good when they have no points, and specificity is really good when they have more than 6 points. But most places, at least in the US, that do structural procedures are not really interested in doing that. This is from the Cleveland Clinic, and I think it's a lot simpler. Low frequency of patients that were found, but the simple algorithm is NT-BNP greater than 1,000, age greater than 70 in male. If you take that and if you have the patients with low gradient AS, then you probably found most of the people who have concomitant disease. A couple other things that I don't have on the slide is the patient who has TAVR and still has symptoms, and if they still have increased left ventricular thickness 6 to 12 months later, then that's probably amyloid because they should have regressed that after a procedure. The other thing is we all have patients who have a lot of symptoms but only moderate aortic valve disease. And we used to say, you're out of shape, it's not your heart, go see a lung doctor. Well, amyloid takes 10 to 15 years to develop, so why are we waiting till they have critical aortic stenosis to look for it? If they have shortness of breath and moderate AS and they don't need a procedure now, it's time to look at those procedures. It's important also to look at patients who have atrial fibrillation and pacemakers. And there's a couple of issues with that. Number one, when they have multiple ablations, they're usually on multiple drugs. And when they have multiple drugs, their resting heart rate is about 60 and may go up to 70. That's not enough for somebody who's got amyloid. I pace all my people at 80. Additionally, if you add right ventricular pacing, there's incredible dyssynchrony there. And so you really have reduced cardiac output. Mitral regurgitation was worse. So we go for CRT, or left bundle block pacing, early on in the disease and get rid of most of the medicines and let them walk around with a higher heart rate. The treatment of heart failure in patients with amyloid differs from those generally recommended in patients with systolic or diastolic heart failure. They certainly have ventricular interdependence, right? So if you diurese them a little bit too much, the left ventricle shrinks, their cardiac output goes down. If, on the other hand, they hold on to too much fluid, the right ventricle increases, puts compression on the left ventricle. The pressure goes up, they're short of breath, but their cardiac output goes down. So you have to be very, very careful in how you use diuretics in these people. So you go from the small cavity that's volume sensitive to the patient who really lowers their ejection fraction and still can't stretch their heart. The atrial, even though they have a P wave in their EKG, the atrium isn't doing much. And then these people are in really low output state. And when I do right heart casts on these people have a very, very poor outlook when they get to this stage and maybe even to this stage. I use SGLT2 inhibitors and spironolactone with judicious use of diuretics in these patients. I don't use ACE inhibitors. I don't use ARB unless they have severe left ventricular dysfunction. Their mortality is increased. You avoid digoxin because the fibers bind to it. And again, you avoid beta blockers unless you need a little bit for heart rate control. So, I'm going to skip that, and we're going to skip that. I'm going to skip that, and we're going to talk a little bit now about disease-modifying therapy, now that we've had it available. Okay? Going back to what we looked at before, the liver makes the transthyretin. You got the tetramers, the dimers, and the fibrils that get deposited. The key is right here. If we can either tighten up this bond or prevent this abnormal protein from being developed, you will have a stable transthyretin with higher pre-albumin levels, and the patients will do better. Much of what we treat now in our country is with tafamidis or acoramidis, and we'll go through that a little bit, but diflunisal is not a bad alternative if you don't have these diseases, if the patient's not anticoagulated and they don't have a history of GI problems. Vutrisiran, patisiran, eplantirsen have different ways of blocking the production of that. If you don't make this, you don't get to that point. Now, we have gene editing that we'll talk about in a little bit, and we have something to remove the fibrils, but we'll talk about that in a little bit. Diflunisal, as I said, small study, but effectiveness is compared to tafamidis if they can tolerate it. I don't think I've had a single 80-year-old who's been able to tolerate diflunisal, but I try it if I can't get anything else for them. The game changer was tafamidis that came out about 5 or 6 years ago. Matt Moore from Columbia reported this in the New England Journal of Medicine. And as you can see here, after 18 months of therapy, the pooled tafamidis group survival was better than the patients who received placebo. 30% reduction in the risk of all-cause mortality at 30 months compared to placebo with statistical significance. 7 or 8 people needed to prevent 1 death at 2.5 years. 4 patients needed to prevent 1 hospitalization per year. And when you look at all these studies, you're going to see a lot of numbers, a lot of curves, which is better, which is not better. The reality is the 2 drugs that we have that are similar are similarly effective. They then extended this therapy out of 42 months. Patients that were on tafamidis or were not on tafamidis, and again, you see the curves continue to verge in terms of survival, in terms of 6-minute walk tests and KCCQ, which were markers of quality of life and functional status. You can see the curves continue to deteriorate in the placebo group on both of these. The average improvement compared to placebo was significant. What you can see here is you haven't made most of these people better, but you've prevented them from getting worse. So if we're going to talk about making people better, we have to find them early before they're too advanced in the disease. Okay? There's something called the Columbia stage, which looks at the diuretic dose, the BNP level, and the troponin, and you can just see here, depending on their 1, 2, or 3 stages, depending on how many are abnormal, you can see that mortality is predicted by that. The other drug that was approved in our country, which I think holds promise for being here, is acoramidis. Now, I talked to you a lot about mutation abnormalities that cause disease. They found that people who had the T119 mutation had a hyperstable protein, and those people did better, lived longer, and even if they had other mutations, they did better compared to those people who didn't have the T119. And so what the company did is try to make a molecule that stabilizes that, and that was reported about a year ago. And again, you can see here in terms of win ratios, whether you're looking at a combination of hospitalizations, mortality, 6-minute walk, and BNP. What they did was they take all the people in the treated group, all the patients in the placebo group, and they compared every patient in one group to all the patients in the other group, and then they went to the next one. They found they were equal, they went to the next level, and they found a win ratio here of 1.8 for everything, 1.4 for cardiovascular hospitalization and 6-minute walk benefit, and then 1.5 for cardiovascular hospitalization. Okay. The secondary markers of quality of life were really very, very favorable here. Whoops. You can clearly see a flattening of the NT-BNP versus a worsening of the placebo. Same thing here, after 18 months, the placebo does poorly with 6-minute walk distance. Kansas City score of heart failure starts to separate about 9 months. Transthyretin level, okay? Because remember, the transthyretin level is important because if you have intact transthyretin, you'll have high levels. If you have amyloid and you break apart those tetramers, you'll have a low transthyretin level because you're only measuring the intact ones. So a higher transthyretin level is associated with a better prognosis. And death from any cause here, you can see down on the bottom, curves were similar, but not overwhelmingly statistically significant. This is a paper from Dan Judge that was a reanalysis of the same data, and really some important stuff. 36% reduction of all-cause mortality or first hospitalization, 42% reduction of all-cause mortality and recurrent hospitalizations, and 50% reduction of annual cardiovascular hospitalization. So if you look here, these curves begin to diverge really, whoops, wrong one, my bad. If you look here, these curves begin to diverge very, very early, at 3 months. Now, you can't have an effect on mortality in 3 months, so it's really driven by first hospitalization. But let me tell you what happens when a patient with amyloid gets hospitalized. All right, they have a very narrow therapeutic window, they're kind of weak, they got bad hips, they can't walk, they get put to bed, they get diuresed, maybe they get too much diuretic. 2 days later, their B1 and creatinine is up, all of a sudden they're getting fluid, they're lying in bed, then they can't walk so well because they've been in bed for 5 days, so they get sent to rehab. They get sent to rehab where they didn't get the right diuretic dose because it was not stabilized when they got out of there. They do worse there. They get dizzy, they get lightheaded or fall, or they get into pulmonary edema. They get back into the emergency room. So a hospitalization really is a sentinel event for people with amyloid. And so the ability to reduce hospitalization, I think, is significant to all of this. Okay? Helios B looks at a drug called vutrisiran. And I don't know when that's going to be available here. It is not a stabilizer, it's a silencer. It prevents the protein from being developed. That's abnormal. There's some reduction of hospitalization, mortality, and cardiovascular mortality. I don't see where this is going to be available here. I want to go back now to talk about acoramidis. I suspect that acoramidis will be approved by the British Health Service by January. I've been talking to the company a lot before I came down here. It's going to be sold, distributed, and marketed by Bayer in Europe. But I suspect if the government here has a way to work with the health service in Brooklyn, you may be able to bring this drug available here. I know the company is interested in doing that. If anybody wants to talk to me, I can hook you up for this. I think if you ask me which of these drugs is better, I can't say, but I think that acoramidis or Attruby is as good as any of them, and I use it in about 40% of my patients at this point in time. But I really think there is some hope for getting some of these patients on disease-modifying therapy, which is good. So where do we stand with future therapy? Well, we have CRISPR that has that gene modification. That's a single infusion that modifies the gene that makes transthyretin, chops out the bad part, puts it back together. We're still in phase 3 of that study. We've got a few people in that. Preliminary data from other CRISPR studies show safety, but we don't know about that. We really thought people were going to jump into this study. But what they're really interested in is monoclonal antibody therapy. Okay? Remember I said, whatever we're doing, we are not taking protein out of the heart or protein out of the nerves. We are stabilizing and preventing disease progression. But if we can then stabilize the patient and then begin to remove the fibrils out of the heart with monoclonal antibodies, then we have an opportunity to reverse the natural history of the disease. We're in the middle of the phase 3 study. It's called the depleter study. I suspect it'll be a year before we have some of those results. I don't know how long it'll be available, but it certainly will be exciting. I don't know what it's going to cost, but it's going to tell us more about management of the disease. Okay? So this is an interesting slide, and it's important, although it's hard to see, in terms of at-risk populations and how it may work here. So if you look at the proportion of black residents in these states, most of the time, Mississippi, Georgia, Louisiana, it's down here. Okay? But if you look at the death rates from amyloid, it's up here in these states. So it's not that these people don't have amyloid in those states. It's we're not finding it and not treating it and not even recognizing it. And that's really my message to you in this country is you have to find a way to find the right people to start recognize it. It's important, okay? This again is the data on the V122 mutation, age greater than 65, heart failure symptoms, mildly decreased ejection fraction, but increased mortality when they do get heart failure and increased prevalence of the disease. So it's important really to think about in the Caribbean, in the Cayman, and actually, we're having the same problems with New York and Chicago and big urban cities there also. Somebody was asking me earlier about how we're doing as we find the disease earlier. If you start on the lower left, you can see we didn't do much of anything, but 2007, about 42% of the patients were early stages. 2012 to 2026, 44%, and in 2017 to 21, 55% were at early stages of the disease, and only about 10 to 15% with late stages of the disease. Then you go over on the right and you look at the purple curves, and you can see that in general, the prognosis of the purple curves was better than the people who were diagnosed much earlier. So finding it earlier does make a difference in survival and in quality of life. Okay? We have a big population in Florida of elderly people. It is kind of a, everybody tries to get to Florida one time in their life once they turn 80. And so I really wanted to look and see, because we have so many patients who have amyloid, does the treatment work for these people? And this is a paper we reported from our database, and you can see that patients greater than 80 and less than 80, the survival and it was the same in these people. So age per se is not a determining factor in treating these people. Functional capacity is a difference, and frailty is one of the big issues. That's the big deals, and how far they progress. And frailty is big in this population because of the coexistent comorbidities. It's interesting. I have found 2 cases of normal pressure hydrocephalus in this population within the last 3 months. And these people have a lot of trouble walking. I didn't look for it, somebody else did, but it makes sense because 5% of transthyretin is made in the choroid plexus, and if this is deposited within the CNS, it can lead to normal pressure hydrocephalus. These are markers for worsening of disease. I'm not going to go over it in details, but basically, are they hospitalized? Are they more short of breath? Did their BNP and troponin go up? And did their echo look worse? Most of the changes we'll see in the first 2 boxes, less in the 3rd box. We do frequent echoes because the patient asks for it, not because they really need it. And that's the same slide there. I'm not going to do this slide because there's a little controversy in it. This I already talked about. So, talked again about hospitalization, but this again looks at acoramidis. If you're on drug, and all these people were on drug, and you were hospitalized, you had a worse prognosis than if you didn't get hospitalized. So these are people not hospitalized, these are hospitalized. So if we can find these people early, do what we can to keep them out of the hospital, we'll be able to improve their prognosis. Okay? So, amyloidosis is a multi-system disorder caused by deposition of amyloid proteins in the myocardium. It's an under-recognized cause of heart failure in the elderly population. It can be easily identified by non-invasive techniques in most people. You must rule out AL amyloid before the diagnosis is made. Disease-modifying therapy is available to stabilize what was once felt to be a terminal disease. And maintenance of quality of life requires multi-organ management. I have basset hounds. I think this really describes where I get the passion for my incidence of amyloid. Okay? If you don't think of it, you won't find it. But if you go looking for it, you'll find it and you can make a difference. So, you remember I showed you that horrible story at the beginning. So this is me in my first year of cardiology fellowship in 1981. Why am I showing you that? Because I admitted one of the index cases of HIV that was reported in by the CDC in the New England Journal of Medicine. We didn't know what we were dealing with. We gave meds, we didn't give meds. All we know was terrible, and they were dying, and eventually we had a lot of meds that we really didn't know who to give to what. This is when people became aware of it. This is Tom Hanks in Philadelphia. But if you look now, a person living with HIV has a similar life expectancy to an HIV negative person if they're diagnosed in time, if they have good access to medical care, and then get treatment for it. And this is where I hope to be in the next 10 years with ATT amyloid. These are just some references there. And if anybody wants the slides, I'll be more than happy to send them to them. So I'll take questions, and I'll thank you for your patience this late in the day.